So this is a 22-year-old female with gradual abdominal enlargement. She initially presented with just amenorrhea, and so she thought that she was getting to be pregnant. Consulted a quack doctor, and she came from the province and was given some herbal medicines. The abdomen continued to enlarge for a year until she came to the city, and the scan was done, which showed a 40 by 30 by 23 centimeter tumor, which was interpreted as an ovarian growth. And the surgeons attempted an exploratory laparotomy, but intraoperatively, they found a liver mass instead, with some bleeding. And so they closed the patient up and referred to our center. At that time, the CA125 was 167. It's very much elevated. Although bilirubin was within normal, direct bilirubin was a little twice the normal. Albumin was very low at 2.1 and hemoglobin at 9. INR was 1.2. So we admitted this patient, and upon review of the CT, this was the huge abdominal mass, which was difficult to really assess. But we were able to find, somehow we were able to find the ovaries, and we know that it doesn't, definitely it's not the ovaries. We proceeded to do a triphasic CT, an MRI, and it shows a T1 hypointense lesion, T2. On T2, it was hyperintense, and there was some hemorrhagic or proteinaceous debris within this mass. It's also with some linear T2 hyperintense signals and some signal drop as well, which probably is some fat components. Radiology couldn't really give us a diagnosis whether it is a angiomyolipoma or a sarcoma or a complex solid cystic lesion. And the patient was severely malnourished, very immobile because of the huge abdominal mass as well. We did a gynecologic exam, and transvaginal ultrasound showed normal pelvis. So we plan to rehabilitate this patient and optimize her nutritionally. She was given nutritional supplements, and we prepared her in the next 2 weeks and planned for a right hepatectomy following this hospitalization. So during here is another view of this patient who's cachectic, also with bipedal edema due to the malnutrition. And the initial incision here shows the entire abdomen with this mass. We proceeded to extend the incision with like a Mercedes-Benz incision. And thankfully, the hilum was stretched out, and we were able to do an extra hepatic exclusion of the right pedicle. And so a right hepatectomy was carried out, albeit the difficulty and some blood loss. Here we lost about 800 cc of blood. It was, the main challenge is unable to see the IBC below and above as well. But we succeeded in doing the surgery for her. And this is the post-operative view. The left liver here, the remnant left liver, as you can see. So this is the lesion with clots, debris, and some necrosis. And on cut sections, you can see the solid and some loculated portions as well of the mass. Now, pathologically, we will see here normal hepatocytes and lined by blood vessels. And then you can see mature adipose tissue and here predominantly epithelioid tissues. So this was signed out as very suspicious for angiomyolipoma. However, with the predominance of epithelioid tissues, there was a need to exclude other types of tumors as well. And so most of the IHC stains were done, but only melan A was positive and HMV 45 were positive. So this was signed out as a hepatic epithelial angiomyolipoma. There's a little background, intro on hepatic angiomyolipoma. These are composed of blood vessels, adipose tissue, and epithelioid tissue, as we've seen. But this is usually seen in the kidneys and very, very rarely seen on the liver. And it's also a variant of angiomyolipoma with malignant potential. And the cases reported, there were only 10 cases reported in the world, and this is the first one we've seen in the Philippines, and especially of this size, this magnitude. 40.34% of them have a high rate of misdiagnosis, including HCC, and really difficult to diagnose in a young female patient when an ovarian new growth with an elevation of PCA125 as well. So as I mentioned, there's only 10 cases reported. So this diagnosis really just relies on pathologic features, and especially with the two immunohistochemical stains that I mentioned. And they don't express markers. All the CA, CA19-9AP, they were all normal. So they don't express any markers of the hepatic tumors. Surgical resection is still the gold standard, and all the 10 cases reported has remained asymptomatic since then. This patient has improved, and as you see from a cachectic picture earlier, she has now, this is 6 months post-surgery, she is now healthy looking and found a job. So this is my case for today.
Catherine, you listen to me. Thank you for being with us from so far. Catherine Tay is professor of surgery in Manila, in Philippines, and she's president of the Philippine Association of Liver Surgeons and Transplant Surgeons. So, Catherine, you listen to me?
Yes, Professor BISMUTH. Yes, I can hear you.
To have you today with us, Catherine. Thank you. Thank you.
Thank you.
It is very sad you are not here, but next year you will be with us. Now, question about your patient.
Okay.
Any questions?
Hi, Catherine. This is Daniel. Good to see you, although from far. This was a typical Manila case, right? Huge tumors. I've never seen as big tumors as you can see in your practice. So, no, I think that liver angiomyolipoma are usually histologic diagnosis on the specimen because it's difficult to make a pre-op diagnosis, right? So, but is epithelioid angiomyolipoma different from regular angiomyolipoma? Because usually we call them just angiomyolipoma, but you added epithelioid.
Yes, because of the predominance of more epithelioid component than the adipose component.
Okay. And makes a difference? It's more malignant?
Recurrence rate is higher.
Okay.
It's more malignant, yes.
Thank you.
And apparently, based on our research, there were only 10 cases reported in the world.
Any other questions?
The main issue here that we had at that time was when to operate the patient, because the patient was severely cachectic, and the difficulty in seeing the vascular structures from the scans really couldn't give us even any idea on volumetry, since the entire left lobe was compressed. It's difficult to do any measure basing on the scans that we have. However, with the large tumor occupying the entire right, as we surmise from the scan that we see. The clue there that we saw was the left hepatic vein. That was the only thing that I saw from the scan. This left hepatic vein, which made me decide that right hepatectomy is possible for this patient because of the left lateral and a little bit of the segment 4, which was probably compressed. So that was the reason why I thought that I decided for a hepatectomy for this patient.
Thank you very much.